Today's topic is about arterial blood gases. So, this is basically a comprehensive explanation of arterial blood gases. Arterial blood gases is a rapid bedside investigation that analyzes arterial blood to evaluate three essential physiological processes. Number one, acid base balance. Number two, ventilation. Number three, oxygenation. So, what is acid base balance? So, in this, we will check the blood is too acidic or too alkaline. Ventilation is the patient elimination of carbon dioxide's effectivity. Number third, the patient is receiving enough oxygenation or not. ABG is one of the most important investigation in emergency medicine, critical care, anesthesia, pulmonology, and internal medicine, as it helps us to diagnose life-threatening condition within minutes. Why is ABGs performed? ABGs is indicated in patients with when there is acute respiratory distress, chronic obstructive pulmonary exacerbations, status asthmaticus, pneumonia, pulmonary edema, pulmonary embolism, sepsis and septic shock, diabetic ketoacidosis, renal failure, poisoning, whether that can be salicylates or carbon monoxide, or when there is altered mental status, mechanical ventilation, monitoring, cardiac arrest, and post-resuscitation care. Then we will discuss components of an ABG. So the important components of ABGs is pH, PaCO2, bicarb HCO3, PaO2, SaO2, base excess, and lactate. So in comprehensive ABGs, the electrolytes level is also checked, including the HB. So pH, normal pH will be ranging from 7.35 to 7.45. What is its clinical significant? So when the pH is below 7.35, it will show us acidic, and when the pH is greater than 7.45, then this will be basic pH. PaCO2, normal range 35 to 45 mmHg, and it basically shows the respiratory component. HCO3, it is 22 to 26 millimole per liter, and it shows the metabolic component, whether the kidney is compensating or kidney's function is good. PaO2, this will be normally from 80 to 100. It is the oxygenation level of arterial blood. SaO2, 95 to 100%. This is the hemoglobin oxygenation saturation. Base excess -2 to +2 millimole per liter. It is the metabolic disturbance or severity. Lactate less than 2 millimole per liter. This is the tissue perfusion or elevated in shock or bacteremia or infection. So what is the interpretation principles? First of all, we will determine the pH. If pH is less than 7.35, it will be acidemia. Greater than 7.45, it will be alkalemia. Then we will come towards primary disorder. If there is, we will check for primary disorder PaCO2 and HCO2. If the PaCO2 is high, then this will be the respiratory acidosis. If the PaCO2 is P less than 35, then this will be respiratory alkalosis. If there is low HCO3, means less than 22 HCO3, it will be metabolic acidosis. If it is high HCO3, means greater than 26, so it will be metabolic alkalosis. Assess the compensation, decide compensation if there is absent, partially compensated, or completely compensated. Assess oxygenation, we will assess oxygenation through PaO2 and SaO2. Then we will calculate the anion gap when metabolic acidosis is present. If there is metabolic acidosis, then will be the anion gap calculated. So how anion gap is calculated? Anion gap is equal to sodium minus chloride plus HCO3 minus. So normal anion gap shall be 8 to 12 millimole per liter without potassium. High anion gap causes are including, it will be high in the lactic acidosis, ketoacidosis, renal failure, toxic alcohols, or salicylates poisoning. We are coming towards the MCQs. So the first MCQ is about a 65 years old man with severe COPD presents with increasing dyspnea. His ABG shows pH is equal to 7.30, PaCO2 is equal to 68 mmHg, HCO3 33 millimole per liter, PaO2 is equal to 58 mmHg. So what is the best interpretation? So basically come towards pH, so it is acidotic. Come towards PaCO2, which is greater than 45, it is primary respiratory acidosis. Come towards HCO3, that is 33, means compensated respiratory acidosis, but it is partially compensated. And the PaO2, which is less than, so this is basically, yes, chronic respiratory acidosis with metabolic compensation. According to me, it's the B option that is correct. So here is explanation. Elevated PaCO2 indicates respiratory acidosis. Elevated HCO3 shows renal compensation consistent with chronic COPD. The pH remains low, indicating incomplete compensation. MCQs number 2. A patient presents after 48 hours of severe vomiting. So ABGs are pH 7.56, PaCO2 49 mmHg, HCO3 42 millimole per liter. What is the primary disorder? So, first of all, pH is 7.56 greater than 7.35 7.45, so it is alkalotic. PaCO2 is greater than 45, it is respiratory. But if we look towards the HCO3, which is 42 millimole per liter, so basically it is metabolic alkalosis with the compensation of respiratory. So number B option is correct. Preventing vomiting causes Persistent vomiting causes loss of gastric hydrochloric acid, producing metabolic alkalosis. Hypoventilation increases PaCO2 as the compensation. Okay. MCQ 3. A patient with septic shock has pH 7.21, PaCO2 24 mmHg, HCO3 10 mm, and lactate 8 millimole per liter. So, what is the most likely diagnosis? So, if we look towards pH, it is acidotic. PaCO2, which is 24 mmHg. So, and HCO3, that is 10 millimole per liter. Okay. So, the first we will. So, it is a little bit hard MCQs. It is acidosis, but it is both metabolic and respiratory acidosis, or it will, in this option, it is not respiratory acidosis, not metabolic acidosis, it is high anion gap metabolic acidosis with respiratory compensation. So come towards explanation. Low HCO3 and low pH indicates metabolic acidosis. The low PaCO2 reflects appropriate respiratory compensation. High lactate strongly suggests the lactic acidosis due to the septic shock. 20 MCQs 4. 25 years old woman has a panic attack. Her ABGs are pH is equal to 7.54, PaCO2 is equal to 26 mmHg, HCO3 is equal to 22 millimole per liter. So pH is 7.5, it is alkalotic. PaCO2 is acidic, so it is respiratory. Acidotic, which is acute respiratory alkalosis. Hyperventilation lowers the PaCO2, raising the pH. The bicarb is still normal because the renal compensation has not yet occurred. So MCQs 5. A patient has ABGs pH 7.40, PaCO2 20, HCO3 12. What is the most accurate interpretation? So it is fully compensated metabolic acidosis. Okay. See, although pH is normal, in normal both PaCO2 and HCO3 are markedly abnormal. A normal pH does not exclude the pathology. The coexistence of a very low bicarb and a very low carbon dioxide suggests two primary disorders occurring simultaneously: metabolic acidosis and respiratory alkalosis.